Yes, ma'am. We can go ahead with the second session, which is for capacity building from tangibles to intangibles. The moderators for this session will be Dr. Chitra Ramamurthy and Dr. Satyajit Sinhaji. So with your permission, ma'am and sir, we can start.
Yeah. Thanks a lot, Dr. Harshul, for a wonderful moderation. I hope you, I don't know if your schedule allows you to stay, and we'll see how it goes. I thought Srinivas Joshi has joined us. He'll be moderating with me. So we have leaders here. It is something like, there is so much of it in the forefront, as much as there is in the background. And how much we take from the forefront and the background decides on the proportion of growth we desire to achieve. We have leaders amongst us here who have actually never limited themselves to the horizon, but have kept reaching to that never-ending line, and thus they have reached where they did. We have with us our past president and an extremely dynamic individual, chairman of the I Foundation Group of Hospitals, Dr. Ramamurthy. We have with us, probably Namrata should join us, our superbly efficient and hardworking honorary secretary, Namrata Sharma, who has taught us how a pandemic could bring with it a vision beyond vision. Has Partha joined us? We have with us Partha, our ever popular chairman, scientific committee, a great surgeon who has led his BBI Foundation group of hospitals with great expertise. We have with us Dr. Avinash Patanjay, who's the director of the GMRV campus of LVPI network, director of eye care education, who has held to the vision of escalating the standards of education to such a high level, because it is that period of life which needs to be really highly nourished and seek its zenith. So he believes in adding to the strength of future, and he's going to be there with us. We have with us Dr. Usha Kim, who heads the oculoplasty department of the Arvind Eye Care Systems, a versatile woman with amazing skill sets and a great administrative initiative. And of course, we have with us our young, dynamic Dr. Srinivas Joshi, who's a member of ARC South, to co-moderate with us. So now we have two speakers with us who are leaders of leaders, who evolved brick by brick their dream plan and taught us that there could be no limit set to the journey of life and the achievements which they have to achieve. We are truly enlightened to have with us Dr. Gulapalli Rao, whose brainchild was LV Prasad Eye Institute, and the amazing stature at which it stands today talks of the genius and the phenomenal mental prowess of this very great individual who made it the best of success stories and believed that growth in the truest sense of the word occurs by creating newer and newer generations of so many young geniuses backed with the highest standards of science, discipline, and culture. We have with us another great human being, Dr. Debashish Bhattacharya, who has reached out to the masses with his Disha Eye hospital chain, who catered to ophthalmology in every strata of mankind, gave the best, excelled on all fronts in ophthalmology, and practically has the Eastern India eating out from the palm of his hand, who also has sought vision beyond vision. We shall be hearing from both these leaders on their various points on capacity building from tangibles to intangibles, and we look forward to our panelists to come up with good discussions on this. So, Dr. Gulapalli Rao, are you there with us?
Yes, I'm very much here.
Could you share your screen? Let's hear from you.
Good. Slide presentation, full screen. Okay. Thanks, Dr. Chitra Ramamurthy. I dare not call her Chitra at this stage. What I'm going to share with all of you is probably a completely different version of what is expected. But nevertheless, since very few people talk along these lines, I thought I would go and give this presentation. When we look at the very meanings of these two words, tangible and intangible, tangible is what is capable of being handled or grasped. That is appreciable, palpable, or perceptible, etc., etc. Whereas intangible is invisible, untouchable. You cannot put a value on this. Coming to our own area, our problem is a major public health problem, global blindness. From the recent data published by the Vision Loss Expert Group in the year 2020, we now have nearly more than 1 billion people affected with significant degree of vision impairment. To that, of course, if we add other numbers of people who really require attention to their eye problems, the number comes to more than 2 million, 2.5 million or so. And 55% women and girls, clearly showing continuing gender disparity around the world. A significant proportion in the pediatric age group. 90% can easily benefit from the existing technologies and knowledge. All this together causes the global economy a loss of nearly over $400 billion. If you look at the progress of what has happened over the past nearly 3 decades.
Your slides are not moving.
Slides are not moving?
Yeah.
It's moving here for me.
Is it?
Okay, now?
No, it's not moving.
I don't know.
How is it for you, Srinivas?
No, madam, it's not moving. GN sir, I think you have to stop the screen share and again,
Share it maybe.
Share it again and do it full screen.
Yes, now it's fine.
Yes, sir.
Yes.
Go back actually.
You could carry on from where you were, sir.
Okay, if you look at the crude prevalence, as you can clearly see in the global map, it's very indicative that we continue to be the leaders in the highest degree of prevalence of blindness in the world. What the hell is that? Srinivas Reda.
Yes, it is. The slide is changing.
So according to The Economist, so long as half the world goes without essential treatment, the fruits of centuries of medical science will go wasted. So what we need is a model of universal basic health care in the true sense of that word. And when we come to India, we have nearly 9 million people blind, another nearly 50 million with moderate or severe visual impairment, with a total number of over 56 million. And these are the predominant causes that are contributing to this problem in India. So what have been the tangible things that we can talk about in dealing with this problem? We have improved significantly in the area of cataract care. We know perform nearly 70% of all cataract surgeries in the world annually. We have more and better approaches in dealing with the uncorrected refractive error problem. We have also greater availability of subspecialization, improved eye banking, and other areas that are within the realm of tertiary care that contribute significantly to sight restoration or preservation of sight to millions of people. And in the area of human resource development through our education programs in the country, we have achieved a significant increase in the number of programs which have also improved in quality, and more platforms of online education are becoming available from our country. This contributed significantly to
All be on mute.
our requirements of human resources, and also helped those individuals who went through these programs with their career advancement or creating careers for many young individuals. In terms of infrastructure, India is on the leading edge of creating innovative models of eye care delivery, covering every aspect, every level of eye care, from the primary care in the remote rural to tertiary care across the country. We have some outstanding examples of such models of eye care delivery across the country. India also has been very successful in leveraging technology, medical information technology, and mobile that have enabled us to enhance our quality of care and also greater coverage through greater reach. And we are the leader in the creation of models of financial sustainability through a variety of approaches that are very much in demand in the rest of the world. So through all this, the tangible thing that happened in India, I believe, that we have become a leader in eye care among the developing countries that has significantly enhanced our stature as a leading eye care country in the world. And in each of these areas, whether it is clinical care or in advocacy, policy, and planning, working with both national and international organizations, India has set several examples and contributed immensely in every one of these areas that you see in this slide. So finally, when we look at the global situation now, the prevalence of visual impairment is decreasing, but the indicated increase in numbers is because of the increase in world population, as well as the fact that the population is aging. So there is a big demographic shift. Eye care, unfortunately, is still not a very integral part in many countries of health policies. There seems to be an end towards the infectious problems of blindness. There is, however, a significant increase in chronic eye diseases that requires significant development of systems approach and campaign approach. And we also have to continue to evolve our technologies to tackle these problems. One area that we have to work on if we want to achieve universal coverage is rehabilitation services. From this, if we go into intangibles, we have to look at the impact on economic productivity of blindness and vision impairment at the individual level, at the community level, and at the national level. And indirectly, all this leads to alleviation of poverty. Blindness and vision impairment also has a bearing on the mental health and well-being of individuals. It's one of the major causes for road traffic accidents and mortality related to that. And it's been clearly shown again and again that falls, particularly in the elderly, are mostly related to vision impairment. In youngsters, it becomes an issue of educational attainment, the employment and better living standards, to reduce inequality, and to enhance benefits to women and girls. In the year 2015, the United Nations has come up with the Blueprint of Sustainable Development Goals, a better and more sustainable future for all the people in the world by the year 2020. Among these 17 goals, in 8 of them, eye health has an important role to play. 1, 2, 3, 4, 5, 8, 10, and 11 of these 17 sustainable development goals have and will be influenced by the quality of eye health we have in these countries. If India were to achieve these goals by the year 2030, as was planned, eye health should become an important part and contribute to it. This is a big intangible goal that we could have. So if you look at it, there are direct effects on the eye health, there are indirect effects or intermediate effects, and ultimately there are outcomes because of the adoption of proper strategies to deliver eye health throughout the country. And no time was all these more pronounced than during the past 2 years of our pandemic. And the economic loss from blindness and vision impairment is significant. Significant reduction in employment, global annual productivity losses, and this is much more in East Asian countries than elsewhere in the world. The World Report on Vision that was published by the World Health Organization last year talked of an integrated people-centered eye care. And that means you are talking about universal eye health that encompasses comprehensive care, that is prevention, treatment, and rehabilitation. Commitment to quality, that is high quality care to all people, closer to the doorstep of the people as much as possible, with continuity of care, not through high camp approach in the future, and community participation in all these efforts. Let me leave you with I got this a few years ago. This really touched me. This is a thing that we see again and again. Most parts of our country on a daily basis. This may have implications to the availability, accessibility,
Not able to see the picture.
many parts of our country.
You're not able to see the video.
End of the sorry to interrupt, we are not able to see the video, sir.
Oh, doctor.
Dr. Gullapalli?
Can we work on a tangible benefit of avoiding such perilous journey to any son of a mother anywhere in the country as responsible, educated citizens of the country. Thank you so much.
Thank you very much, Dr. Gulapli Rao. But it's just that we missed watching that wonderful video, but we heard a great music.
Oh, you didn't get the music?
Yeah, but I had watched this video before, so I actually have a very basic question. Your talk was just mind-blowing, amazing. You know, we know that you have multiple centers in tertiary and middle, and the very primary of your centers, you may not be having a doctor in those centers. You may be having a some kind of an optometry training.
Right.
So sometimes they could miss out some of these eye condition and the need to be seriously evaluated. Could those have a medical legal implication? Because, you know, when we start growing, we try to grow so expansively that there could be these issues. How do you prevent that from occurring?
So we are very clear, Chitra, that primary care is intended to be served by mid-level ophthalmic personnel. Knowing full well in our rural and tribal areas, no ophthalmologist will ever go and practice. No optometrist with a 4-year degree will go there and work. So that's how we innovated this model of recruiting the rural youth who completed just class 12 or intermediate, train them to be well-qualified technicians. And the key is the rigor of training, how we train these technicians. Our technician can match the best of optometrists in the way they can examine the patient. These vision centers in the tribal and remote rural areas are fully equipped, and now they are technology connected with teleophthalmology. So the main purpose is, since more than 50% of the vision impairment is uncorrected refractive error, these technicians can provide correction for them. And then the second purpose is recognizing potentially blinding diseases. They can recognize them. They may not make an accurate diagnosis, and then refer them to the next level. And all these centers are within a 50-kilometer radius of a secondary center of ours, where there are ophthalmologists. So they take care of the next level care. And they also get an immediate opinion if they want through the teleconsultation from the tertiary centers.
Dr. Avinash, are you there with us?
Yeah, I'm there, Dr. Amurthy.
Yeah. So what would you have to say about the kind of leadership which you have seen in your institute and which could be given away as a message to our leadership desiring audience? It's a very...
Right. And when when you talk about the leadership, I would just like to focus on what Dr. Rao's leadership is all about, because it's something which we have seen and we have felt and we have grown with it. And so there are many people who have disappeared into the oblivion, and few people have snatched a couple of great attributes which could be called legendary from oblivion. And we all know that attributes of Dr. Rao are legendary. And actually, thanks for an opportunity where I can speak something about my chairman. Actually, there are very few people who get this opportunity to talk about it in front of him. But having said that, I can talk about many multiple things, but there are 4 which I can very vividly recollect. And these are all like very short stories. One is a story of sacrifice. So when he had to make the decision of moving from America back to India, that's a story of sacrifice. That's a sacrifice where he walked at the helm of his academic life and very comfortable living there and coming back to his roots. That's a story of sacrifice. And the second is the story of being an innovator. We just heard that he spoke about innovations and how it made the difference in rural eye health care. And his personal favorite about his quote from Robert Frost, taking the path least taken, and that made all the difference. And that's the short story of being in the innovator. I spoke about the story of sacrifice. I spoke about the story of innovator. And then the story of excellence also touched me a lot. So it's not only preaching, it's like a role model for us. When we work with him, we see that when he focuses on something, he immerses his head, heart and hands into that. And that's what pivots an excellence in whatever he does. And the fourth is story of compassion. And one of his statements, which really stays back with me many a times, and all the time rather, would be, poor should not be treated poorly. So these are, I would say, very touching stories, which, when we look at people like Dr. Rao, who we easily adopt as a role model, and these are the ways in which their role modeling has influenced me in whatever I am today. To just recollect those four important story points, I would like to say about story of sacrifice, story of being an innovator, story of excellence, and story of extreme compassion.
Thank you, Avinash sir, for that wonderful comments. Sir, question to GN Rao sir, please. Sir, we have heard about the LVP. Who doesn't know about LVP? We have heard about your iSmart technology also, which we are using it, where Anthony Bipin Das gave a good demonstration. You're not just into the eye care, but also more into innovations and also into the technology. So when you talk about the universal health care, because I studied in Canada, my fellowship, where after 50 years, you are the property of the government. The government takes care of everything. Whether you take Health Canada or the Obamacare or the US healthcare system or the NHS system in Europe, they all are governmental based, and that's how they have been able to grow up so high. But when I saw about the LVP model, you have probably more than 200 vision centers and nearing, I think, 300, if I'm not wrong, right? So it has become a kind like it automatically feeds patients to their tertiary care centers. So do you think that we have to join hands with the government, or is the government has to really necessary? This is a 1.3 billion populated country. Individually alone, how can we achieve in these the universal health coverage, especially when it comes to the eye care? Or can we do a sustainable, like how you have developed the vision care centers where avoidable blindness free villages, which you people are declaring? And is that the way to go, or join hands with the government? What is the actual way to go, sir?
A very good question. We have to remember LV Prasad Eye Institute, what we have done even with our 240 locations is only a model. And innovation happens in social or private sector. And scaling up is the responsibility of governments. And if we have to get the universal health coverage for the entire population of our 1.4 billion nearly, government has to do it. There's no way out. No non-governmental organization or a coalition of organizations can achieve that. So we are working with the 3 state governments where we are located, encouraging them. And in all the 3 states, we have actively become their technical or training partner to not only influence through advocacy, the examples being the Kanti Velugu programs in Andhra Pradesh and Telangana in the last 2 years, where they screened the entire populations, spending significant amounts of money. The first time such large volumes of money were spent in a year's time, 150, 200 crores in one shot. And we were happy that we could play an important role in that. And we also work with them in training, in education, their residents, their professors, etc., etc. So that we have to continue to do, work alongside the government, encourage them, play a role in advocacy, both at the national and international level. That's an important responsibility of our profession, advocacy. If we neglect it only for our peril.
Dr. Ramurthy, do you have anything to say to summarize this before we go on to Dr. Debashish?
Rather than saying something, I have just a couple of quick queries to Dr. GN Rao since he's here. Great talk, Dr. Rao. A couple of things just concern me was that, we have been having this talk about this Vision 2020 document for a long time. And where are we situated right now? I mean, have we gone around achieving at least part of what we set around to do it in the year 2010? And second thing is that in spite of all the advances that we have made, whether it is institutional, governmental, or individual, most of our practice still seems to be cataract centric. With the aging of the population, RMD, glaucoma, diabetic retinopathy, all these things, I do not think are still getting the kind of attention that they deserve. Any thoughts from you as to how we can change this scenario?
Yeah, the first question, Vision 2020 has helped in making the progress, has helped in putting the eye care and prevention of blindness on the radar screens of policymakers around the world through very, very significant lobbying and advocacy efforts. For the first time, the World Health Organization has put prevention of blindness and eye care as one of the healthcare priorities within its mandate. And that is the achievement. And then few countries have moved significantly in advance, and many countries have now begun to actually give a line item in the healthcare budget for eye care on their national budgets, which never happened in the past. Those were the positives, but we still have a long way to go. The successes are trachoma, onchocerciasis, vitamin A deficiency, significant advance in the area of cataract surgery. We have only created awareness and some models for uncorrected refractive error. We have a long way to go. Diabetic retinopathy, glaucoma, etc. We only are at the beginning of developing a framework for their care. They are still within the realm of tertiary care. Until we cascade it down to secondary and primary and clearly divide the care, we will not be able to handle those. As for the second question, I think we have to continue to apply our advocacy efforts with policymakers to get the kind of prioritization that we truly deserve for eye care. If you look at it, I give you an example. When I was the Secretary General and later the President of IAPP, that was the time when we were looking for the World Health Assembly resolution in the WHO. And we made phone calls to all the 193 country members of WHO, to one of our friends, either a leading ophthalmologist or optometrist, and asked them, is the President or the Health Minister or the Prime Minister your patient? It turned out most of our friends are very close to these leaders. And if they could use that to the advantage, to our advantage, that connection, then I think eye care will get its due prioritization. Most of us are connected to these powerful policymakers, but we should use it, leverage that. And then I think we can achieve it.
Thank you very much, Dr. Gulapi Rao. It was wonderful to have you here, but I want you to stay on with us. And let's hear from Dr. Debashish. I hope I get an entirely different viewpoint of the same sentence.
Yeah.
We
Right.
have to part.
Yeah, Chitra. Definitely, it will be different. Right. Can you see my screen?
Yes, yes.
Yes.
So, Chitra gave me this topic because she wanted me to talk on the same lines, and but as is clear, I am in a AIOS ARC Leadership Development Program, a very privileged moment when you are with the future of AIOS leaders. I would rather see that what intangibles we don't see, and how we can actually try and work something forwards. So that would be my viewpoint. And as a leader, I think we all need to learn from our chairperson ARC, Chitra, how to be in it, actually, how to be in it. She's really in it. How we can be prepared to give, which is most important, and ready to receive. Because any giving act will reciprocate in the other person giving you back. But we need to process it and correct and move forwards. So essentially, I would see a leader as the lead strategist. He should be responsible for selecting his team, for designing a unique, workable model, and to take it forwards. And in all this, he is the person center. So he has to, strategy is all about making choices. So it is not that I can do this and I can do that also. It is about I will do this. So that focus is important. Now, as Dr. Rao was saying, how are we poised here? See, I mean, very different from the rest of the bloc. We are at a per capita which is much below 5,000 per annum, dollars per annum. Where is India with a CSR in the cataract surgical scenario? As close to developed countries like Japan, and there are many below, Canada, so many below us. And this is what great teachers, great mentors like Dr. Gunapalli Rao and their institutions have done to the Indian scenario. They have cascaded a total system of capacity building, renovated the entire game of eye care, and has made it into a simplistic model that even practitioners like me could latch on and could start thinking of having a hospital and taking it forwards. But having come here, focus on the last bottom line. For the last 3 years, the CSR in India is probably just the same. And if you say, oh, are we now going to go down or what's going to happen next? Well, no, I mean, we, as Dr. Rao said, there is a huge demographic backup. If we compare the 45 to 55s, the 55 to 65s, because these are the backup age groups which come up, the pyramid looks pretty okay for us. I mean, that way it is fine. And if we look at our institution, hospitals figures, then we probably stand as what more could we have done? Like almost a 60% with vision better than 612 at operation for cataract. Essentially, we have reasons to think now that probably we are not working at the total level. We are working in a very limited sphere of place. So let us explore this area and go forwards. If we see the, the industry gives us good figures. So I took these figures that what is the PMMA and hydrophilic lenses? That's about 50% of the total IOLs used. And then comes the second group where the per capita is between 8,000 to 24,000. And then comes the 10% group. So probably we are going around this 50% bracket, whereas this upper 50%, the 0 to 8,000 rupees per month income range group is something which eludes us. And as Dr. Rao said, it is for the government to take up, and it is for us also with the growing economy to see what is possible there. We have to explore. Now, let us compare another scenario, that this is the amount of anti-VEGFs being used in India. And this is the major, but I would rather focus on this 3,50,000 figure. Whereas if you see any developing country, and this is only 1/20th of the total cataract surgical volume. Whereas if you see any Western world stats, it is 1 to 2 times of cataract surgery. So we should be giving 65 lakh anti-VEGF. How far are we back in this? Okay, AMD considered the 3 regime recommendations of ETDRS. Let us treat PRN, but still too, it has to be at least half of cataract, that at least 10 times more than what we are doing today. How do we go there? I mean, if you see the cataract statistics of Disha, which is a totally paying hospital doing 70,000 surgeries, this is the profile which also substantiates the slides that I showed. Now, having said that, there is an intervention ratio to various procedures, and this is across the 12 lakh patients that we see annually. This is the intervention ratio. I mean, to 1 retina injections, we see 115 patients. So essentially, at a 6/12, 6/9 cataract vision at operation, the injections being 1/20th, whereas we need to times. I think what is most important is that we need to focus on comprehensive care, and that too, there are the problems of this wide territory, the economy, and the cost. Just imagine if we just take the retina injection. If we subsidize this 300 rupees, 30,000 rupees would be to just find out a case which would benefit from injections in this distribution. But this is not the scenario. At economies of scale example, I'll give one of this, that doctors don't want to do indirect ophthalmoscopies. So we bought this Optos machine and put it in hospital which sees 500 patients. So at 30 patients a day, at just rupees 300, we could recover the cost of the machine in 3 years. And it diagnosed peripheral lesions better, there was better compliance, and the patients actually got lasered. And now we have 6 of these Optos equipments around us. So is the laminar flow care, which also economically becomes so viable. So all this, we can really think of. So essentially, from a private sector point of view, we often ask this question, the big question, what does the patient want? We have to provide everything. But the patient wants everything, that's the problem. So a better question probably would be that what is the patient willing to pay for? And that is the start point, that is the real need. That is the felt need, and that from there we have to come to the real need. So it is from aspiration to affordability. And we have explored from our little data points that it is probably 1 days per capita in the OPD, 1 month per capita for a cataract surgery, and 3 months, which is equivalent to 3 months of the square feet cost of the residential area, some equative standards. And another thing I would always say, that the staff can afford the average cost of cataract surgery, but that is the affordability level we need to focus on and work on. So fair price is a very important thing, and we need to fair price our surgeries properly, transparency, and this package brings faith and creates aspiration and leads to better compliance and a better word of mouth publicity, and propels growth. And probably, social marketing improves a unique value chain system which can actually propagate forwards, and we can carry an organization to replicate and to perpetuate, which is most important. So location is very important. It has to be a growing elderly population with young, vibrant economy, expandable, visible, accessible, underserved or fringe areas are important. retiring practices or joining some practices are other options. Having said that, we spend our preparatory years, but then as an organization, it resembles a life of a human being. I mean, as the child years from 0 to 5, it is to a surgery center with 1,000 to 2,000 square feet, small practices which contribute and form the major part of the private sector offering to eye care. And then as we hit these critical numbers are important because we are working on a very shoestring thing, and we have to price our products very affordably. So we cannot have sleeping costs, and we have to have the best capacity utilization, do maximum with little. So everything matters: the recruitment, marketing, growth, collaborations at every stage, group practices, innovations, outreach, which Dr. Rao said was so important. And then, as you grow, you can have a mix and match of surgery centers, vision centers in the rural or semi-rural areas, diagnostic centers, so to say, in the city, and have a mix of all of them. And at the 30 years beyond, we also need to think not that an institution, goes down the order. So phasing out, passing the baton, and perpetuity should start focusing on an organization like ours with me on the chair at this point of time. So this is our growth of OPD patients. This is how the branches came up, giving a small example of these 4 yellow points, which when we first entered the city, we created 4 centers in the 4 corners of the city. And finally, we also went around a little we followed our following. Wherever we saw there are 50 patients, 100 patients coming from a district town with a radius of around 100 patients per day in a radius of 100 kilometers, we started a capacity hospital of 300 to 400, and very soon it would be utilized. And these 4 centers we now accumulated into our new town facility, which is kind of a dream for us. So this has been our growth curve of cataract, retina injections, and retina surgeries. So this is, you can just have a snapshot look at it. So growth has been an important propellant in this. And these are the revenues when the last year was COVID. So you can well see a revenue dip of 20%. I think all the staff and the doctors did amply well in these difficult times, and we could sail through majorly without much of an hiccup. Now coming to the main point where we were talking, this is one equipment. This is a photograph from one equipment, and these are the quality of photographs and the OCT and the angle OCT and the pachymetry and the anterior OCT and the angle OCT. So it has everything. Now this equipment is probably, can be bargained down to 15 lakhs. If you, and I am sure, I mean, if we go further on, and if everybody, what I'm trying to say, let vision centers have it. I mean, if we are talking of, Chitra had been talking about the issues of technician diagnosing maybe an angle closure or a diabetic retinopathy. But when you have this, you can definitely understand that this patient has diabetic retinopathy. All our technicians understand that. And then it can be forwarded. Telemedicine for prescriptions are obviously fine. If we can have this, this is the next stage that I'm trying to focus on. I mean, let us have vision centers with this one device, and it could be the most useful teleconsultation setup. So this is a thought which I leave you with. And well, cost is more important than quality, at least in our circumstances. And I definitely consider him as a very wise person, but quality is the best way to reduce costs. And obviously, when we are in a so technical world, simplification of technology so that the intangibles become tangible is something that we always look forward. Thank you very much for your attention. Thank you very much.
Thank you, Dr. Debashish. That was a very practical talk which you shared with us. Can you hear me?
Yes, I can.
No, because suddenly my screen has gone. I would want comments from Dr. Ramurthy and Dr. Avinash. I think I need to get connected again. Dr. Ramurthy, are you there?
Yeah, I'm very much here.
Yeah, I think you and Dr. Avinash have to get connected again. Not able to see all.
Your picture is coming, but
We are all
No,
there.
we are able to see him, madam. Ramurthy sir, go ahead, sir.
All of you.
I can't see.
Lovely talk, Devashish, and very practical. Nothing less was expected of you. You know, this apart from talking about general aspects, you also have to give some messages to the attendees. One of the things which struck me about your practice is that, you know, it's not a very high-end practice. It's not the extreme, the top end that you are targeting. At the same time, you're not doing any free service. You know, it's the middle level you are been catering to, and you have been extremely successful with that. This is not the model that most of us have. You know, we have people who are at the top end catering to the people with the highest of paying capacities. Then you have institutions who mid-level as well as the community ophthalmology practice. How did this idea come to you? And you know, there's also a mass practice, and you have been able to build upon it. And what is your advice to youngsters who might want to follow your footsteps?
No, essentially, as I said, first we need to have a very proper understanding of the location. In fact, you know, the choice of location also matters in a big way. Because any eye care service depends upon its proximity. I mean, people cannot come from far off places unless it is an absolute tertiary care facility. So the location definitely guides, but I think pricing is very important. And essentially, if we follow the growth of our OPD, the interventions that we require, I mean, how many interventions are we doing for a patient? How many patients are we seeing? How many cataracts are we doing? What is our compliance? If we follow that, we can price our services better. And so essentially it would be to get as many people in. So affordable pricing, fair pricing is a basic requirement, and some risk taking around that is also probably justified. That maybe, you know, if we, you might say, you know, that it's undercutting. You know, another private practitioner may feel that it's undercutting, but it's not really that. Because it is generally, you have to follow systems. You know none of the consultants are big names. So they are basically skilled and trained well to perform at a good level. So that is the quality that an average eye care seeker looks forward to. And if we can attend that, I think there is scope. So we should. But more importantly, I think there is more scope in the base of the pyramid, especially around comprehensive care, because the other things over this 35 years, the cataract ball game, I think is, you know, how far can you go? And you're operating 6-9 cataracts. I mean, where can you take it from here? So.
Dr. Avinash, a brief comment. I think we are running short of time.
No, it's just a question which I wanted to ask both Dr. Rao and Dr. Bhattacharya, in terms of, because when we interact with a lot of youngsters, you know, one of the naive questions they ask is, Doctor, since they are so much involved in learning ophthalmology or even various subspecialties, how do you know that I have become a leader? So there's a question for both of you. Like,
Dr. Rao, are you there?
Yeah.
Yes, doctor, we want from you.
I don't know if there is a very easy answer. The one thing that I think as an indicator that you are a leader is, for me, that if I have the discipline, and then I have certain habits that inspire others, the small ones. It doesn't have to be a big inspiration. And then others begin to follow you, and you see others doing the things that you are doing and imitating. Then I know that person is a leader. The person who has instilled that kind of confidence in others through self-discipline, through their systems, and inspire others to follow them, you can see that there is a leader there coming up. And also the other thing that we do in, as you know, Avinash, is in our system, we give them an opportunity to run a small section of the institute and see how they do. That's the second stage.
Absolutely.
And that's in effect a pilot project on their leadership skills. And that's how we have always built our pipeline of leaders. And we've done fairly well.
Yes, you have, Doctor.
Definitely you have.
Yeah.
Yeah, I would say that, the moment Avinash, a youngster, has a dream, and that dream is keeping him awake, and then you understand and you start talking, then that youngster will start talking. He will start talking with his friends. Some, because he keeps on talking about it, will become his foes, will, move away from him. And if that dream, which, he starts enacting it, so he lives that dream every day. So it is, that is why dreams are so important. And when the opportunity comes, the opportunity will definitely come. We say that, ophthalmology is getting tough, everything is getting so competitive. But no, I would say even a penny beggar on the street has a better day. So he will or she will get an opportunity, and how you latch on to the opportunity will depend of how intensely you have dreamt of that moment, so that you take the moment forwards. And obviously, as Dr. Rao said, these virtues are most important. Sacrifice is a very simple word. To give is so simple. And when you give, you automatically become a leader, and things will follow. It will keep on coming, because if you give, the returns will definitely come back. So obviously, time's up. So,
Dr. Srinivas, you have anything to say?
I have a question to Debashish sir.
Yeah.
Debashish sir,
Yes.
you have been a costing guru, right? I saw where you people operate at around 18,000 rupees for an IQ or a Technis lens. And I was told that you were asking for the Femto PI interface, cone interface at 8,000 rupees when it was available in the market at 23,000 rupees. So as Ramurthy sir rightly asked the question, so you are onto low cost and the high value kind of practice. How is it even possible for everyone to replicate? Second question, you don't have...
You can't ask two questions. We don't have time.
So last one, madam. You don't have DNB or fellowship programs as of now, as I understand. But still you have enormous centers and you have a very good human resource in ophthalmology. It has become very difficult to get a good ophthalmologist nowadays in the peripheral centers. How have you been able to tap up these young minds?
So to take your first question first, we had DNBs. Now we rely on fellowships only, because being a paying hospital only, we cannot use patient resources to, teach people, which is LV Prasad is that is why LV Prasad is LV Prasad. So we can't take patients' money to, teach people. So we teach people only whom we absorb as consultants. So that is a recruitment mechanism. But DNB was previously, but since they started that you can, we cannot choose our DNBs. DNBs will come through the entrance, and so then we left DNBs. So, and regarding this urban and rural thing, the youngsters actually goes 3 days in the rural area, in the semi-urban district towns, and 4 days they enjoy city life. We give an outstation allowance, and of course, happy patients are everybody's goal, but if we must have happy doctors to give happy patients. So we keep them happy.
Thank you, sir. Thank you. Thank you very much.
Thank you so much.
May I answer one question that was raised? Is that okay?
Ma'am, actually, we're running out of time.
Okay. Just to answer that question for the youngsters on how do you identify yourself as a leader? One question, the minute you start thinking, the minute you start raising questions, and the minute you start reassessing what your leaders have done and finding your own ways, I think we start getting getting to fit into the role of a leader.
Great.
And I'm talking in the midst of
No.
leaders, but this is how I would look at ourselves and the youngsters, that the minute you start thinking, you are becoming a leader.
Great, Usha. So, Chitra, thank you for a lovely session. Nice seeing you, Usha.
Dr. Chitra, actually, you're on mute. If you could just unmute the mic.
Yeah, I didn't realize that.
No problem.
Thank you very much, Dr. Debashish. Thank you so much, Dr. Gullapalli Rao. There was so much of energy which came in after hearing your talks.
Thanks so much
Thank
for
you.
the invitation.
Thank you, Dr. Avinash. Thank you, Dr.
Thank you
Usha
so much.
and
Thank you.
Dr. Ramurthy. I would be happy if you all can stay on the next session and hear two great stalwarts talk to. This is going to be Dr. Mahipal and Ramurthy in the next session. Do stay with us and add to your thoughts. We'll be most
I mean.
Yes, Dr. Debashish.
I mean.
Yes, thank you so much. So we shall now go on. Thank you very much.